Good morning, everyone, or afternoon, I guess it is now. And thank you for joining us. I'm very excited to introduce to you my friend and colleague, Dr. Mona Zufante, who is the Winnebago Chief Public Health Officer. She's a member of the Seneca Cayuga Nation of Oklahoma, and she grew up in the northwest suburbs of Chicago, so she has a lot of roots. She pursued her undergraduate degree at Northland College in Ashland, Wisconsin. I'm not good at my state abbreviations, Mona. And studied environmental studies, which prepared her for a variety of experiences. She completed her master's in public health at Concordia University in 2017 and has earned her PhD in the Indigenous Health program from the University of North Dakota in 2023. Professionally, she's been the Chief Public Health Officer for the past 11 years. She is also a very busy part-time EMT for the Winnebago EMS program for the past 21 years. And prior to that, she was the environmental health specialist for 14 years. So she has a long history, dedicated history of really being a part of the public health movement in the Winnebago community. She spends many hours, many hours, to serve on several boards, many that I get to be on with her, to help elevate the discussion about the needs of the Indigenous people, oftentimes specifically Winnebago, but Indigenous as a whole, nationwide and globally. And in her spare time, she enjoys spending time with family, along with beading and sewing a variety of projects. She, like me, has children. Okay, just 1 minute. She has 4 children and 3 grandchildren, and she enjoys spending time with them. She's an amazingly wonderful colleague to work with. I'm adding on here. She's also an amazing road warrior. And she just is a happy, positive, dedicated public health servant. And I'm excited to hear what Mona gets to share with us today, and my son is too. Take it away, Mona.
And thank you, Regina and family, for attending the session and for the wonderful introduction. So I appreciate it. So let's see if I can share and actually start from the beginning. And oh, okay. I am always technically challenged. So let's see. Where did that little bar go? Oh, there it is. Okay. Sorry. So you don't have to see everything. Here we go. All right. So this is the work that I did under in my PhD program, but it's also the work that I do here for the Winnebago tribe in Nebraska. And so thank you for all attending today to learn more about this work. It's my supporting positive mental health, well-being in Indigenous youth and young adults. Okay, let's figure out how to go next. Here we go. All right. So I always like to start with a land acknowledgement. And so I would like to recognize and acknowledge the Indigenous people of this land, the Poncas, the Santee Sioux, the Omahas, the Winnebago tribe in Nebraska, that we gather today in various areas, I think within the state of Nebraska, perhaps others, because I know Gina's not in the state today, and perhaps other regions outside of Nebraska. And I want to acknowledge those Indigenous people of this state. They've been the stewards through generations of the lands and the waterways of what is now the state of Nebraska, and we honor and respect the enduring relationships that exist between the people and the nations and this land. So I dedicate not only my PhD, but obviously all the work that I've done up until this point to my family and of course the ancestors that have allowed me to be the person I am today. I continue to do whatever I can to make positive change to improve the lives of our people. And I try to share the knowledge I've gained to empower the next generation to continue to reach for those stars. So the framework that I used I'm going to move people. Okay. This framework was developed under the guidance of the Aboriginal and Torres Strait Island Mental Health and Suicide Prevention Advisory Group. It was created in 2017. And so the social and emotional well-being views the self as an inseparable form and embedded within the family and community. The self is surrounded by 7 overlapping domains that are sources of well-being and connection. The model also acknowledges the history, politics, and society all affect the social and emotional well-being of Indigenous people. And the connection to body refers to the physical health, and to incorporate physical activities into programming keeps people active and healthy. The connection to mind and emotion is the ability to manage thoughts and feelings, and that is fundamental, of course, to one's overall health. And then the connection to family and kinship is a sense of belonging, identity, security, and stability for Indigenous people. And then the connection to community provides connections with each other, support each other, and the work that they do together. And then connection to cultural, maintaining the sense of cultural identity by participating in practices associated with cultural rights and responsibilities. The connection to land is where the nourishment for the body, mind, and spirit are reconnected and grounded. And the connection to spirituality and the ancestors is a sense of purpose and meaning. So I chose this framework because it really encompasses all that is important to me as a researcher, an evaluator, and an Indigenous person. The foundational piece is to keep our mental health in balance, and then everything else will be able to work itself out. So let's see. So what I first did was a review of existing data set to determine influences on mental health well-being in Indigenous youth and young adults. So just some background information. As many of you know, there are 9.7 million people in the United States who self-identify as American Indian or Alaska Natives. This population represents about 2.9% of the US population. There's about 573 federally recognized tribes throughout the United States. The American Indian Alaska Nation populations are culturally diverse, have distinct languages, cultural practices, ceremonies, traditions, and histories. And they reside in the US geographic regions all over, and they show various degrees of assimilation into Western society. This diversity can also lead to inaccuracies with health data that are reported to in the aggregate for American Indian Alaska Natives for different regions. It is also estimated that there are about 13 suicide attempts for every completed suicide in the American Indian Alaska Native population. It is also estimated that more than 40% of adolescents who die by suicide have made previous attempts. And those who have attempted are 20 to 50 times more likely to die by suicide than peers without a history of suicide attempts. Suicide attempts are also associated with depression, substance abuse, or substance use, loss of family members or friends to suicide, availability of firearms, a history of physical or sexual abuse, and some of the same risk factors for suicide attempts among adolescents in the general population have also been found in the American Indian Alaska Native youth populations. Oh, and I need to pay attention to my slides. So this is what I all just said. Sorry about that. You can see that. Now we're continuing on. So my research really utilized Nebraska as a state of focus. This study seeks to critically review 2 well-established national data collection tools to answer really 3 questions. Among the 2 national data sets, what are the common outcomes related to mental health and well-being among American Indian Alaska Native communities? Among those same sets, what are the differences, if any, among reported outcomes related to mental health and well-being among those communities? And then really study and reviews the 2 data sets for commonalities and differences among the mental health well-being questions and determine whether further questions need to be developed to get really to the core of how to develop programming to address suicidal related behaviors among this community. So my sample was, so in 2017, the total American Indian Alaska Native population of Nebraska was about 1.8 million, which was about 1% of the total population. And as you can see, there are 4 federally recognized tribes within Nebraska, which includes the Ponca tribe in Nebraska, the Omaha tribe in Nebraska, the Santee Sioux, and the Winnebago tribe in Nebraska. 3 of the tribal nations are land-based. There are several urban clinics serve the American Indian Alaska Native population, and there is one currently tribally ran hospital that is located on the Winnebago reservation. So in 1984, the Centers of Disease Control and Prevention launched the BRFIS, a random digitized dial telephone survey measuring health risks in non-institutional American population over 18 years of age. The BRFIS, as it's called, is a questionnaire is designed by a working group of state coordinators and CDC staff. They have standard questions that are changed periodically to reflect current research on known morbidity and mortality rates. And currently the questionnaire has 3 sections. They have a core component, which is always used in administering the BRFIS and is not modifiable in the format. And then there's optional modules and state added questions. The core component is a standard set of questions asked by all the states, and it includes queries about the current behaviors that affect health, like the tobacco use, women's health, and then demographic characteristics. And then the optional CDC models include questions on specific topics like smokeless tobacco, and then the states elect to use on their questionnaire. And then although the models are optional, CDC requires that they be used without modification if they're actually used. And I also looked at the Nebraska YRBS, which is the Youth Risk Behavioral Surveillance System, which is done every 2 years. And I kind of looked at 2009, 2011, and 2013 surveys, which are anonymous paper and pencil questionnaires administered to 9th through 12th graders in the classrooms during a single class period under the supervision of school personnel. The schools notify parents about the survey by a letter and use a passive parent consent procedure. And then students were told that their participation was voluntary, that they could refuse to complete the survey or complete specific items, and then they could quit the survey at any time. Excuse me. So the total sample of the Nebraska BRFIS was about 14,000. Among that total sample, was 389 that identified as American Indian. So when reviewing the social determinants of health and other demographic variables within the BRFIS, a greater percentage of persons who are American Indian than those who are white reported no education beyond health, high school, unemployment, poverty, and low medium annual income. And so you can see by the percentages, of course, more females answered the survey, and then we had more that were 18 to 39. So the suicide rates were lower for Nebraska American Indians when compared to the white Nebraska population. For this survey, the death rate of 9.7 per 100,000 population of suicide for American Indians were 1.2 times lower than that for whites, which was at 12 per 100,000 population. American Indian adults in Nebraska were statistically more likely at 26.7 than white adults to report fair or poor health. And then American Indians reported being mentally unwell for an average of approximately 5 days compared to whites with 3 days. And then 27% of American Indians have been diagnosed with depression compared to 18% of whites. And so you can see the breakdown now of the YRBS. we combined 2009, 11, and 13 surveys to increase the number of American Indian students for this analysis. So only the data for 9th to 12th grade who identified themselves as American Indians were examined in this report, and there were no questions about tribal affiliation that I found. And so you see that between females and males were pretty much very closely. And then you see not so many 14-year-olds, but then it grows in the 15, 16, and then 17-year-olds. So the following are the questions from the YRBS that were related to my particular research questions. So during the past 12 months, did you ever feel so sad or hopeless almost every day for 2 weeks or more in a row that you stopped doing some unusual activities or usual activities? And 69% reported no. During the past 12 months, how many times did you actually attempt suicide? 89% had 0 times. One time was at 7.6, and then it fell off after that. If you attempt suicide during the past 12 months, did any attempt result in an injury, poisoning, or overdose that had to be treated by a doctor or nurse? And then 88.9% indicated that they had not attempted suicide. 31% of the YRBS respondents indicated that they had felt sad or hopeless almost every day for 2 weeks. And then 2.9% indicated that they had attempted in the past 12 months, which resulted in being treated by a doctor or nurse. And there were really no questions about the strengths of mental health well-being or what made them feel better or why they felt unwell. So the discussions and limitations, both data sets are self-reporting and might not be a true representation of the population. And neither of the data sets that were selected had strength-based questions. And so I was thinking, what do we need to do? Well, we need to work with those that administer the surveys to incorporate questions to determine the strengths of those individuals who do not have a negative well-being, and how we can enhance those to positively affect the others in the population. There should also be including some questions regarding what cultural protective factors that the respondents participate in can assist with determining what impacts that the culture has on our population that may be different from other populations. And then a further study could be conducted to dive further into what programs or activities can be developed to decrease the adverse mental health well-being in the population. So my next one is, I like this one. So I like qualitative too, clearly. And so I did a qualitative study that explores the influences, again, on mental health well-being in Indigenous and youth and young adults. And so my area of focus was the Winnebago tribe of Nebraska, which is home to about 2,737 residents. And of those residents, about a little under 2,000 are enrolled in the Winnebago tribe of Nebraska. So the Winnebago tribe is located by that star on that map, is in the northern half of the Thurston County, which is northeast Nebraska, and it spans about 120,000 acres. The reservation is about 20 miles south of Sioux City, Iowa, and about 80 miles north of Omaha, which are the nearest urban areas. So the aim of this particular research was to explore what suicide prevention activities would be beneficial to decrease suicide-related behaviors among American Indian individuals in the age groups of 12 to 24 years living on the Winnebago reservation. So this study aimed to explore the characteristics that should be included in a suicide prevention program and activities for ages 12 to 24. In this study, American Indian, Alaska Native adolescents and young adults shared their perspectives about suicide prevention through key informant interviews, which were carried out in the month of May 2023. So I focused on individual accounts of experiences and then conducted the analysis. The University of North Dakota and the Little Priest Tribal College were the institutional review boards that reviewed and approved this study. So my recruitment eligibility included the Winnebago community Indigenous youth ages 12 to 24 years of age. So this excluded everyone that's parents did not sign the permission slip, anyone older than 25 or younger than 12, anyone who did not identify as Indigenous or who did not live in Winnebago for this study. I also recruited participants through flyers, emails, social media. The participants themselves with their peers, people interested in participating were asked to contact me directly via cell phone or Facebook. I did not recruit specific individuals within the age group, so I used a non-probabilistic sample methods to obtain 10 participants ages 12 to 18. And then that was considered our youth group. And then 10 participants in the 19 to 24 years, which was the young adult. And then the recruitment ended after the conclusion of the final interview for each 10 respondents within the age groups. So all adult participants were provided with written informed consent. All the participants under the age of 19 were provided parental consent as well as youth assent before starting the in-person interviews. I followed a semi-structured interview protocol. I asked questions. I allowed the participants to respond and elaborate. Participants received a $35 gift card, and the interviews really ranged from 20 to 40 minutes. And the interview topics included mental health, the programs, suicidal related behaviors and activities. All interviews were coded or recorded with the consent from the participants, which then were transcribed. All the transcriptions were manually checked for anonymity. Participants were checked for corrections of their comments, and then a coding framework was developed once the transcript was conducted based on those themes. So I had a total of 16 participants that identified as female, 4 that identified as male. In each group, the youth and the young adults, I had 8 that identified as female and then 2 that identified as male. So you can see the breakdown looking at that table that the ages were kind of all over the place. So 1 out of 10 in the youth group had participated in previous suicide prevention program activities, and then 3 out of the 10 young adults had participated in previous activities. So for those who participated in previous activities, those activities ranged from attending lock-ins to suicidal-related walks. So incorporating cultural practices. So both the youth group and the young adults identified as a need to weave cultural activities throughout any local suicide prevention programs. So 75% of the participants identified cultural practices as crucial elements and shared activities like cultural camps, regalia making, hand games, attending powwows, spiritual activities such as sweats, Native American church, or praying, and storytelling as important. There are also 6 participants who described the need to include history and storytelling as a part of that. The need to increase the number of cultural activities the youth can participate, including a weekly round dance or a calendar that includes all of the annual events would be helpful. Some participants described the importance of reclaiming their family tradition and stories, since some of the youth needed someone to guide them. So one of the young adults heard of a healing camp in another tribal nation. And this is a quote from her, a healing camp where young adults can get together and learn about historical trauma because we never discussed it. I never understood why I was so angry until I learned about it. And all of our youth need to learn. So incorporating physical activities was also very important. They felt that that could help with depression, being around other feeling positive. Participants suggested these physical activities from horse riding, nature walk, softball, basketball, gym workouts. One participant discussed needing more spaces for young people to access. They indicated creating a sense of belonging can add to the learning with language by incorporating names in Ho-Chunk through walks or through the activity would be important. Oh, shoot, I skipped ahead. I'm so sorry. I did tell you I was inept. Okay, so here we go. So the next one was involving elders and youth suicide prevention. So 95% of the youth indicated that elders working together on activities or learning from elders should be included in the activities. They thought that historical trauma, again, was brought up, is a foundational knowledge that all need to understand. We need to understand why we do things to make those changes and be healthier. So these are straight from our young people. The participants suggested that elders can demonstrate the resilience of our people, which can be conveyed to the young adults, sending the messages despite the negative factors that have plagued us, we can still overcome and move forward. The participants indicated that they wanted to learn from elders' lived experiences, and half of the participants indicated that working together on cultural projects would be ideal, like telling the stories about the history where we come from and the teachings from the past, cultural activities such as hand games, because those are fun and the kids would love them. They also wanted to create a sense of belonging, a space to be heard. The majority of the current activities that target the youth group are targeting the youth, like under 18, but there are not many for the young adults, 19 to 24, they indicated. About half of the participants indicated a need to have a space for the youth to speak and have someone listen to them. Providing a sense of belonging is really vital to the youth. It was described throughout the interviews as decreasing depression within our community. They also felt it was important to acknowledge that there were some opportunities already established at our behavioral health program. However, having other areas for the youth to drop in, such as a drop-in center, would be beneficial. They also talked about having a support group to be able to provide that needed space. So some things that I learned from them that they did want to be avoided in any activities or programs that we have, they should not be lengthy or boring. They did not want anyone to be made to feel guilty if they did have suicidal thoughts. They did not want to be talked down to or judged for the activities or path that they have created for themselves. They also want to make sure that the program was a positive one. They also wanted the people that were involved in the activity to be genuine. They didn't want them to be fake. They wanted to be surrounded by passionate people who wanted to be with them and listen to them. So some of the discussions and limitations, both of the young adults and youth shared interest in the suicide prevention programming that incorporates culture, involves physical activity, incorporates elder teaching, avoids stigmatizing the language, and lengthy programming. A search of the research is that the data was collected directly from American Indian Alaska Native participants. Some of the limitations, the sample set that was non-probabilistic, the first 10 participants of each age group that could participate did. So it is not based on whether the participant was from like a single parent or two-parent family, from a certain socioeconomic background, or engagement in any particular cultural activities. As a result, the sample set was not equally distributed across these demographics. A second limitation of this is that many of the adolescents were challenged to elaborate on activities that they thought would benefit them. Most of the youth had not participated in existing suicide prevention programs, and therefore they really didn't have any framework to draw from. The third limitation is that this would be localized really to just our area. It might not reflect other tribal nation children. And the fourth was that 80% of the respondents, as we see, were female. So the male perspective might have provided a slightly different viewpoint on these. But in conclusion, the participants offered multiple specific activities that could be considered based on the resources and feasibility. The concept of a healing camp, allowing young adults to transition from adolescence to a young adults, opportunities for young adults to learn about historical trauma and intergenerational trauma in a safe environment. And then future research could be conducted the same study after the activities have been implemented to see if there's any movement to decrease suicide-related behaviors. And then future programming in the community should always include the voices of the youth. So my final piece was taking all of this information that you just seen and really developing an evaluation plan in response to suicidal prevention activities and implementing that into our Winnebago Public Health Department. So the Winnebago Public Health Department is in Winnebago, Nebraska on the Winnebago Indian Reservation. And then organizationally, the program is under the Winnebago Comprehensive Healthcare System since its inception in 2018. The Winnebago Public Health Department is comprised of 15 field health programs, primarily responding to the public health needs of the Winnebago community. We have offices all through Winnebago. Primarily, we are in the basement of the hospital, but we also have programs throughout, and we also have one office in Sioux City. So we did a community health assessment back in 2019, was conducted by the health department, and the strengths were culture, tradition, education, our diabetes program, the Unity, and the Whirling Thunder Wellness program. Also, we during that same community health needs assessment, we found the weaknesses were behavioral health, obesity, cardiovascular disease, cancer, and tobacco. So from that, we developed two priority areas, and we had, oh, wait. So we have, did I skip? Yes, I missed. Well, anyways, that's okay. We'll just continue going on. So, so the main programs for this evaluation will be included are the Health Promotions and Education Program, which their main activities are are at health fairs, some for one-day focus activities, as well as other programming. They have a program staff of 4 full-time that can assist with this particular project for the oversight and educational activities for the community. We also have our behavioral health program that also participate in health fairs, and they also provide outpatient therapy. There are 5 full-time therapists within this program that can also provide support and guidance with the health promotions and education program. So this program will be evaluated for its effectiveness for specifically incorporating specific interventions within the Winnebago community by providing culturally appropriate and youth-centered interventions. So there are numerous stakeholders that are involved in creating the suicide prevention program for the youth and young adults. The health promotion, obviously, and education staff would be the primary staff members that would be involved in implementing this program. But we also have the behavioral health staff will be assisting as well, because they have the mental health training and they can provide treatment services directly to this identified age group. Also, programs that would be impacted by suicidal related behaviors would be our human services and it's called YCIC, which is our Youth Crisis Intervention Center. Of course, me as the Chief Public Health Officer, our Winnebago Comprehensive Healthcare Board of Directors, our CAO, the Tribal Council, our community members, and of course, our most important stakeholders are our youth and young adults to keep them involved in the activities and programs. So our implementation strategy was really to develop a youth council tasked with providing health knowledge and developing activities that are designed for this age group, then designing a suicidal prevention program, and then hosting a healing camp targeting our young adults ages 19 to 24. So looking at the Youth Council, one of the initiatives would be to develop this council with ages 12 to 18. This council ideally would meet bi-monthly and would be managed through the Health Promotions and Education Program. This council would be presented health information that will be used to help design some of the activities to provide feedback to the programs. The objective of the council is to increase the health education awareness. And then there would be, of course, pre and post-test, key informant interviews or focus groups, and then program staff records to determine the effectiveness of the interactions with this particular council. And then the suicide prevention program objectives will be decreasing suicidal behaviors among youth and young adults, specifically ages 12 to 24. The outcomes assessed will be through the data collection on the suicide attempts, ideations, and completions. There will also be youth mental health first aid classes, question, persuasion, and reasoning classes, and others that will provide to this age group to aid in the signs and symptoms and getting to the appropriate assisted programs. These classes will be open to ages 12 and older. They will also be held on a quarterly basis. The health promotion education program and other stakeholders within the community will assist with hosting these classes. And then the measurement tools that we will be program staff records, attendance logs, participant usage records, our own 12 Clans Unity Hospital emergency room visits, and also our emergency medical services transports. So now looking at the healing camp is aimed to increase the process of healing among our youth and grounded in culture and traditions guided by the youth. The theory of change is that if the community members are grounded in culture and traditions, this would lead to a decrease in health impact seen by all community members and participants. The outcomes assessed will be to assess cultural connectedness. The healing camp would be targeted at 19 to 24 years of age. This will be conducted initially once a year, and then the camp will incorporate ideas about historical trauma, intergenerational trauma, transition from adolescent to adulthood, as well as other culturally significant activities for this age group. And then the measurements will again be pre and post-test program staff, attendance records, baseline health measures, and yearly follow-up by the outreach staff. So the evaluation for our framework, we're really using the CDC's framework for program evaluation will be one of our guides to make sure we're engaging other stakeholders throughout the evaluation to provide feedback and input from both adults and youth. And so our aim, of course, for all of these is to determine the effectiveness of those three main activities, to determine if those activities have a positive impact on our participants, to increase health awareness, cultural awareness, and ultimately the reduction of suicidal related behaviors in our community. And then we will evaluate this after the year that it's been implemented. And then based on that feedback, we'll make modifications on the programs. So we developed a logic model. And so the development of the youth council, first we want to identify and invite youth, provide a health orientation to that youth council, start having bi-monthly meetings with them, and then include the youth in development in any of the suicide prevention programs. And then designing the suicide prevention program, we will consult, of course, with the youth council on their input, review existing toolkits, and then get training for the staff, and then distribute flyers, and then, of course, select those participants to participate. And then hosting the healing camp, we need to review other tribal nations' healing camps if possible, determine the content that should be included in the healing camp with input, of course, from our young adults, consult with our Ho-Chunk Renaissance program on those activities. That's our language and cultural revitalization program. Also solicit from other programs to assist with the camp, and then again, distribute flyers and select participants. So some of our outcomes, of course, short term is to increase the knowledge amongst the youth council, and we would measure that through pre and post test, receive feedback from the youth for those focused programs by the youth council, establish the suicide prevention program with activities, evaluate the pre and post test for effectiveness, increase the participation in the healing camp, increase the activities within that healing camp, and then increase the cultural knowledge for participants. And some of our medium term, I guess, would be increase health awareness within the community through educational activities, increase the awareness around suicide-related behaviors, and then ultimately decrease the ER visits for suicide-related behaviors. And some of our long term is to decrease suicide-related behaviors amongst this group. increase the use of our services, continue to have the youth participate in the youth council, have community members really take ownership of that healing camp and program, and improve the health outcome for our healing camp participants. So we can see some of the evaluation activities for the youth council. We would have a training of the youth council members to become health champions to lead a better health outcome. And we do that indicate through pre and post measures with that orientation, and have annual training based on the top health impacts. We will also look at the utilization of the youth council as a resource for input into the youth focused by measuring how many programs are presenting to them. And then is the youth council able to fulfill their mission to be impactful? And then we would use a questionnaire to evaluate that. So the suicide prevention program evaluation activities would be, is the selected toolkit being effective? And so we would use a pre and post test for that. Was the program effective at decreasing the ER visits for suicide related behaviors? So we would look at ER data for that. Is this age group seeking services more than before the implementation of that program? And we would look at our behavioral health data as well as our 12 Clans Unity outpatient data for behavioral health related services among this age group. And then the evaluation activities for the healing camp, are the camp participants increase their capacity to manage loss, trauma, and grief in a healthy way? That has pre and post questionnaires. Is there an increase of family and cultural connectiveness? And again, pre and post tests. And then are there more partners once the implementation of the program compared to the pre-implementation? And so those are baseline measures. So those are, in the nutshell, all the things that I've worked on, and we are starting this fiscal year. We will be implementing that evaluation plan. So hopefully in another year, I will be able to tell hopefully some of the successes of our activities. So thank you. And if there's any questions, I can try to answer. I will stop sharing somehow. Those are my references, and I will eventually stop sharing somehow. Okay, there we go. No, stop.
I have a question. I always have questions. I'm Carol Gilbert. I should share my videos. So I'm always interested in the data and how the data can steer you right or wrong. I know you talked about the BRFIS data and the YRBS, but BRFIS, I just remembered there was something like 390 Native Americans in the BRFIS sample. And I wondered, there were several sort of differences within Native Americans, kind of demographic differences like socioeconomic status, whether they got health insurance through the tribe or through their jobs, whether they were rural or urban, whether their cultural connectedness. And these seem like they could be important as far as their health outcomes. And I wondered if you think about how they do the BRFIS study with a random digit dialing, do you think they would get all those groups in a fair way, or do you see any possible source of a systematic bias in that survey?
So definitely how they do the telephones, because a lot of us don't even have landlines anymore, and we have cells, and a lot of our relatives here change phone numbers like they change their shoes. And so it would be hard to get a good, I think, sample from that source. But I know that with the new data that we should be seeing, is that we teamed up with the state of Nebraska to actually do the BRFIS. So we administered the very last BRFIS to get a better sample size. We worked with them, and I think all of the tribes participated in that as well. And so we all had certain markers of people that we tried to get. And I think we in ourselves had over 300 people that participated from our tribe. And I believe they just released that just a few weeks ago. So I don't have that for comparison, but I will eventually look at that. But there's a lot of great data in that. And I know talking to one of the directors there is to make sure that they do the Nebraska American Indian status. That was not sent out with this last one, and that was done in 2019. But so we just have this specific, like I just have specific Winnebago data. And so of course we would have to go through IRB to share any of that information with others. But I think that in itself, reaching out to the tribes and working with us to not do the telephone, we went and had different events that people could come down and participate in. And then they got a gift card, and that Burfus is a lot of questions, and they didn't get a lot of money for that when you think about it, but they showed up, and that was very exciting to be able to do that and have people sit there with them, especially our elders that sometimes have a hard time reading some of those documents to be able to understand what they say. So a lot of our staff that was did this actually had training on what the Burfus was and what the questions meant. And if they asked this question, then this is what it meant, to help them through that. So I'm hoping that we continue to do that in the future if Nebraska is going to continue. And if not, then we, at least in the Winnebago tribe, would probably be doing that ourselves and start doing the Burfus internally. We already do that with the YRBS, or the Youth Risk Behavioral Health. So one of our entities, not within the health department, but another entity facilitates that, and then they work to get that data back. And so they're working on it right now, actually. So it should be exciting to make some trending and some and hoping that we've made some differences.
Yeah, thanks.
I have a question. This is Josie. Hi, Mona. Great job, by the way. How long would the youth sit on the youth council?
So it wouldn't be very long. So we were looking, so we're developing the, like, not so much policies and procedures, but basically that. So we were looking at least a year term or a school year term. And I'm sure that there'd be some that are very active, so they would come back again. But we wanted to make sure that we kept opening it up to new students to be able to participate, to keep getting feedback on activities and programs. And of course, the older ones would transition out because they're going into their new stage of life, I guess. And then we would always have new freshmen coming in. So that was what we thought, is that it would be a school year term, and then we would look at new ones.
Any thoughts on thinking about pipelines for healthcare, workers? Because that's always needed.
It certainly is. And so we are hoping that the youth council would want to participate in obviously the health department, public health specifically, because none of us are getting any younger, myself included, and also working with our higher education program. So we have a job summer youth program. And they have started looking at doing internships through the year. So we're trying to tap into that. But again, it's a little bit hard because they are under 18. So trying to figure out how we can give them a good experience, that they'll want to come into some public health field, but also respecting the clients and the relatives that we already serve, and trying to figure out, because we don't want the youth only shredding, that's so easy for them to do clerical work. But we want to give them experience, like going to do a home visit, or being able to ride along on the ambulance. So doing other things, but clerical is so important too, because, obviously I'm an administrator, so I need someone to take over. but so trying to figure that out. So we're still, but I'm open to anyone that knows exactly what to do. I'm totally open to how we get them in our pipeline more than what we already do.
That is awesome. Just have a couple more questions. Have you been able to receive any funding to help you with this project?
So I have not specifically this particular project yet, but we are looking at different areas, and of course we get Indian Health Service funding for our programs. So just trying to incorporate it into the programming that we already have, so it is more like something that we're going to repeat. So that's why I really want to make sure that our programs take hold of it, because then it's more apt to be included in their programs and things that they're just going to keep repeating and doing. And so like, just like how we do breast cancer awareness, right? We do that every October, you know, we find speakers, we make sure we do a walk, we do these things. So I want this to be a part of that, is that the youth council is something we do every single, you know, we start it up and then we continue it. We do the healing camp, and then we do the suicide prevention programs based on, you know, what the youth really want, not what we as adults think that they should want.
That's great. And the final question, is there a suicide hotline that within Winnebago that you could measure? Maybe I missed that. Maybe you talked about that already. Is there a way to measure like the calls and stuff like that?
We do. We have so of course everyone has an opportunity to use 988, and we are working with 988 to figure out how do those particular calls come back to us.
Got it.
Because it's very important to us to be able to track our relatives that are, you know, in crisis, to get them into counseling or into something, so that we make sure it's not a one and done kind of thing. So that is in the works, but we also have our own crisis response number, I guess, that anyone can call, and they will get one of our current therapists. And it's a 712 number that they can call and be able to reach them. We also received a SAMHSA grant for a community crisis response. So we're working on that as well. And so it's a mobile response. And so you basically would just have to call the police department. It's in the works, so it's not all worked out, but we're developing. You would be able to call the police department, and then they would be able to dispatch, they would know, because they would get training of what a behavioral health crisis. And then they would be able to send this team out, not like SWAT or anything, but, you know, like incognito to this location, to be able to talk to that relative and be able to decide whether we can send them home on a safety plan. Can you follow up the next day with our staff? We'll check in with you. Or are you elevated to go to the emergency room? So this team, so that not everyone has to go to the emergency room, because they don't, you know, sometimes we just need to talk through things, and that can be done. And so that's in the works now, and we're hoping we're going to have a huge kickoff in October with our partners, or this month, I guess it is October, and then be able to start really rolling out our policies and procedures and really getting that in place. We're also looking at establishing our own behavioral health stabilization unit. So that would be in coordination with this community crisis response team, so that they would also have another opportunity to help and engage our relatives that are in crisis.
Awesome. Again, great work. I know that sounded like a lot of work. So thank you for sharing. I appreciate it.
Thank you, Josie.
Yeah.
Good to see you.
Hi,
You too.
Can I have questions? So my name is Kwan, and I'm an assistant professor in UMC neurology. And I have wonderful talk. Thank you very much. And I have two questions. One is, because I study social connectedness between within a family, and I'm curious about what is the best way, the measure to study the connectedness to the society. So that's like my technical question. And the other one is I'm really excited about your finding, say so the younger generation, they feel, the interaction with the elderly is like, for health. And can you just say more about that? It's like their family members, their grandparents, or it's like anyone in the community or strangers? Thank you.
Okay, so we know that there's tools out there for like cultural connectedness. So we were going to allow the youth council and then of course our other staff to kind of look at those particular measures and then to decide what is the best one to use here to be able to measure that. And so we wanted to make sure everything was really culturally based and came from our community. So we wanted to make sure that they were the ones, like I didn't want to dictate to them, this is the one that we should use, right? Because you always think that you know best, and I do, but I like them to pretend. No, I'm just kidding. But we wanted to share all that with them, and then they are the ones that really drive it. And so that's how we wanted to do that part. So with the elders, they really talked about some of our youth don't have elders in their home. Some of them don't have multi-generational houses, others do. And some don't have grandparents. Unfortunately, life expectancy among American Indian Alaska Natives are really still not very old yet. But I hope we're fixing that or working on that, because I know we are. So they talked about a lot of different things. We have a senior citizens center within Winnebago about connecting with them, being able to do cultural projects with them at the center, being able to bring them in some way. So I've started to work with the activities coordinator that we have at the senior center to look at those projects and start working with our Boys and Girls Club, so that we can start bridging those gaps. But they also talked, so that's one area is to utilize what we already have and utilize those programs to be able to. They also talked about like even having an elders bench. So where an elder would be sitting in the community and it was a safe space for the youth to be able to come and sit with them and then just visit with them. And so I'll be looking at creating that as well to see if we could get different elders to just sit at a bench and then having youth come and visit with them. So those are the two the main ones that they talked about when we were visiting, I guess. It was harder to get things out of the 12-year-old for sure. And then up until about 14, 15, it was really hard to like get stuff, but it was important. And it was good to hear from the really young people too about what was important. So I hope that kind of answered your question.
Totally, thank you so much. And I just want to make one comment. So the interactions between the youth and the older adults is also beneficial to older adults. It's a bit,
Yes.
bi-directional. Thank you so much.
Yes, for sure. Thank you.
Mona, quick question. This is Jessie. I was just thinking about the Nebraska Native Youth Gathering and maybe how some of your data could help inform the types of sessions or even like giving that, like even having a youth-led session about how they were able to share their perspective and help inform some of this work, really elevating youth voice and agency. So I was just, do you see that as like, would you be willing to have the youth share some of the data or the findings that you collected? Is that in the future or in the realm of possibilities?
I could definitely ask. I know of a few of the older ones, probably the 19 to 24, that would be most comfortable being able to do that. And I would definitely be open to that. And I think there's a few of them that would too. They're very vocal.
Awesome. Thank you. Well, I'll follow up with you, but.
Okay. Yes.
Any final burning questions? No. Mona, thank you so much for sharing your work with us and answering all of these tough questions with great answers, thorough answers too, that keep us thinking, you know, and moving this work forward. So grateful that you're a part of the Idea CTR, part of my life, and can share all that you do with us, because I know that this work carries on in all of our lives, and all that you shared with us will definitely strengthen our approaches to community engaged research. And just thank you, Wado.